Our first topic is thoracic wall. Let us first discuss the basic anatomy under thoracic wall. Basic anatomy is the study of the minimal amount of anatomy consistent with the understanding of the overall structure and function of the body. Under basic anatomy, we have two topics. The first is descriptive anatomic terms. Second is basic structures. So first we have descriptive anatomic terms. The accurate use of anatomic terms by medical personnel enables them to communicate with their colleagues, both nationally and internationally. Without anatomic terms, one cannot accurately discuss or record the abnormal functions of joints, the actions of muscles, the alteration of position of organs, or the exact location of swellings or tumors. We have here terms related to positions. We have three: median sagittal plane, coronal planes, horizontal or transverse planes. So first is median sagittal plane. This is a vertical plane passing through the center of the body, dividing it into equal right and left halves. Second is coronal plane. These planes are imaginary vertical planes at right angles to the median plane. So the third one is horizontal or transverse planes. These planes are at right angles to both the median and the coronal planes. Next, we have terms related to movement. We have flexion, extension, abduction, adduction, medial rotation, lateral rotation, circumduction, pronation, supination, protraction, retraction, inversion, and eversion. So we have flexion and extension. Flexion refers to a movement that decreases the angle between two body parts. Extension refers to a movement that increases the angle between two body parts. Next, abduction and adduction. Abduction is a movement of a limb away from the midline of the body in the coronal plane. Adduction is a movement of a limb towards the body in the coronal plane. Next, we have medial and lateral rotation. Medial rotation is the movement that results in the anterior surface of the part facing medially. Lateral rotation is the movement that results in the anterior surface of the part facing laterally. Next, we have circumduction. It is the combination in sequence of the movements of flexion, extension, abduction, and adduction. Next, we have supination and pronation. Supination is a lateral rotation of the forearm from the pronated position so that the palm of the hand comes to face anteriorly. Pronation is a medial rotation of the forearm in such a manner that the palm of the hand faces posteriorly. Next is protraction and retraction. Protraction is to move your shoulder backwards, and retraction is to move your shoulder forward. Next, we have inversion and eversion. Inversion is the movement of the foot so that the sole faces in a medial direction. Eversion is the opposite movement of the foot so that the sole faces in a lateral direction. So let us now proceed to the second topic under basic anatomy, which is the basic structures. First structure, we have skin. Skin is the largest organ of the body. The skin protects us from microbes and the elements, helps regulate body temperature, and permits the sensation of touch, heat, and cold. Next structure, we have fascia. It is a connective tissue. It connects every part of the body with every other part, wrapping around muscles and holding organs in place. Next is muscle. Muscle is contractile tissue grouped into coordinated system for greater efficiency. The three types of muscles are skeletal, cardiac, and smooth. For skin, There are three layers of skin. First is epidermis, second is dermis, and third is subcutaneous tissue. For fascia, there are two types. First is superficial fascia, second is deep fascia. For muscle, there are three types: skeletal, cardiac, and smooth. So let us now proceed to the joints. There are three classifications of joints: fibrous, cartilaginous, and synovial joints. Here are some terms and their definitions. Ligament is a cord or band of connective tissue uniting two structures. Bursa is a lubricating device consisting of a closed fibrous sac lined with a delicate, smooth membrane. Synovial sheath is a tubular bursa that surrounds a tendon. Blood vessels are the channels or conduits through which blood is distributed to body tissues. So now we have nervous system. We have two main parts of nervous system: the central nervous system and the peripheral nervous system. Central nervous system. It consists of the brain and spinal cord. It is composed of large numbers of nerve cells and their processes, supported by specialized tissue called neuroglia. Next is peripheral nervous system. It consists of 12 pairs of cranial nerves and 31 pairs of spinal nerves and their associated ganglia. Next we have the bone. It is a living tissue capable of changing its structure as the result of the stresses to which it is subjected. Classification of bone. Long bones, the example is femur; short bones, the example is carpal; flat bones, the example is frontal; and irregular bones, the example is vertebra. Now let us proceed to the next topic, the structure of the thoracic wall. Thoracic wall. It is covered on the outside by skin and by muscles attaching the shoulder girdle to the trunk. It is lined with parietal pleura. So thoracic wall, it is formed posteriorly by the thoracic part of the vertebral column, anteriorly by the sternum and costal cartilages, laterally by the ribs and intercostal spaces, superiorly by the suprapleural membrane, and inferiorly by the diaphragm. Next topic for thoracic wall is sternum. Sternum. It lies in the midline of the anterior chest wall. Sternum is divided into three parts: monobrium, body, and xiphoid process. First part is the monobrium. It is the upper part of the sternum. Second part is the body. It is the longest part of the sternum. Last is the xiphoid process. It is a thin plate of cartilage that becomes ossified at its proximal end during adult life. No ribs or costal cartilages are attached to it.
So, I'm going to discuss about ribs. The ribs are the primary structure of the thoracic cage which protects the thoracic organs. So, our ribs are flat, curved bones that make up the majority of the thoracic cage. They are extremely light but extremely resilient, which helps them protect the internal thoracic organ. So, we have 12 pairs of ribs in our body. And our ribs can also be divided into three categories, which are through ribs, false ribs, and floating ribs. So the ribs 1 to 7 are considered true ribs and attach directly to the sternum via their own costal cartilage. And the ribs 8 to 10 are the false ribs and are connected to the sternum indirectly via the cartilage of the rib above them. And the final two pairs of ribs are floating ribs, and the cartilage of these ribs tends to end within the abdominal musculature. So the configuration of the lower 5 ribs gives freedom for the expansion of the lower part of the rib cage and also for the movement of our diaphragm. So our ribs are also have different parts. So we have thoracic vertebra, manubrium, and sternum which is located at the center, xiphoid process, and the costal cartilage. So our ribs can also be classified as either typical or atypical. So ribs 3 to 9 are the typical ribs, and the major landmarks are the head, tubercle, neck, and the body. The head is expanded and typically presents two articular surfaces separated by the crest. The neck is a short, flat region of bone that separates the head from the tubercle, and the tubercle projects posteriorly from the junction of the neck with the shaft and consists of two regions, which are the articular part and the non-articular part. So the first, second, and 10 to 12 ribs are known as atypical. The head articulates with the body of vertebra and has only one articular surface. The tubercle has a facet for articulation with the transverse process, and this scalene tubercle separates the two smooth grooves. So next will be the costal cartilage. And I will be talking about joints of chest wall, joints of ribs, and movements of the ribs and costal cartilage. So costal cartilage are bars of cartilage connecting the upper 7 ribs to the lateral edge of the sternum and the 8th, 9th, and 10th ribs to the cartilage immediately above. So they help to extend the ribs into a forward motion and contribute to elasticity within the walls of the thorax, allowing the chest to expand during respiration when breathing. Next will be the joints of the chest wall. The dome shape of the thoracic cage is formed by two joints. First is the manubriosternal joint, which is a secondary cartilaginous joint between two parts of the sternum, which are the manubrium and the body of the sternum. Second one is the sternal joint, or also known as the sternociphoid joint. It is a symphysis between the inferior margin of the body of the sternum and the superior margin of the xiphoid process. It ossifies with age in most people, becoming completely fused by the age of 40, creating a synostosis. Next will be the joint of the heads and of the ribs. The first rib and the three lowest ribs share a single synovial joint with their respective vertebral bodies. The head articulates with corresponding vertebral body and the vertebrae above it through a synovial joint for the second to 9th ribs. So, joint of the tubercle of the ribs. A rib tubercle articulates with the transverse process of the corresponding vertebra through a synovial joint. Joints of the ribs and costal cartilage. These joints are cartilaginous joints, so no movement is possible. Next will be the joints of the costal cartilage with the sternum. The first costal cartilage connect to manubrium by the cartilaginous joints that allow no mobility. Synovial joints articulate the second to seventh costal cartilage with the lateral border of the sternum. Furthermore, the sixth, seventh, eighth, ninth, and tenth costal cartilage articulate with one another via small synovial joints along their borders, while the 11th and 12th rib cartilage are embedded in the abdominal musculature. Movement of the ribs and costal cartilage. During expiration or breathing out, the ribs move down and medially. During inspiration, the transverse diameter of the thorax is increased by the ribs swinging outward. The combination of these movements allows the rib cage to increase in the anterior, posterior, and the transverse diameters. Last one will be the opening of the thorax. The thorax has openings, the superior thoracic aperture, or also known as the thoracic outlet. It is called an outlet because important vessels and nerves emerge from the thorax here to enter the neck and upper limbs. The superior thoracic apertures open towards the neck. So, the thoracic outlet is bounded by the first thoracic vertebra posteriorly, the first pair of ribs laterally, and the superior border of the manubrium anteriorly. So, next will be the intercostal space. So, intercostal space are the spaces between the ribs. So, it contains three muscles of respiration. First, first is external intercostal muscle, which are located in between each rib starting at the first rib and extending down to the 11th rib. Second one is internal intercostal muscles, which are located immediately deep to the external intercostals. Last one is innermost intercostal muscles, so it fills the 11 intercostal spaces between the ribs together with the other intercostal muscles.
So good day everyone. I'm here to talk about the thoracic wall. Thoracic wall. It consists of a body framework that is held together by 12 thoracic vertebrae posteriorly, which give rise to ribs that encircle the lateral and anterior thoracic cavity. Functions of thoracic wall. The structures of the thoracic wall protect the heart, lungs, and the great vessels, as well as some of the abdominal organs. Here is an example image of the thoracic wall. In our right side, you can see here the anterior scalene, the diaphragm, the transverse thoracis, the intercostal artery and vein. While on the left side, we have here the subclavian artery, the internal thoracis, and the internal intercostals. Intercostal muscles. Intercostal muscles are muscles that are present within the rib cage. It consists of three layers of muscles: the external, the internal, and the innermost layer. They combine to fill the space between the ribs. Intercostal muscles helps to stabilize the chest wall in full of inspiration. They contract to prevent the intercostal spaces being sucked inwards by the negative interthoracic pressure generated by contraction of the diaphragm. They lie in the intercostal space between the ribs. There are three types of intercostal muscles, namely the external intercostal muscle. It connects the rib in such way that the contraction of the muscle lifts the rib and rib cage and expands the anterior-posterior dimension of the rib cage. The role of the external intercostal muscle is the accessory of respiratory muscles. It elevates the rib during forced inspiration. The internal intercostal muscle is a group of skeletal muscle located between the ribs. There are 11 in number on either side. They pull the sternum and ribs upward and inward. The functions of the internal intercostal muscle is the accessory respiratory muscles. Together, the innermost intercostal, they are enabled to force expiration by the ribs. Lastly, the innermost intercostal muscle. They are the deepest intercostal muscles located in intercostal spaces. They contract along with the internal intercostal muscles to reduce the transverse dimension of the thoracic cavity. The functions of it are similar to the internal intercostals. They assist breathing by depressing the ribs and support the integrity of the thoracic cage. Intercostal arteries and veins. So, it giving a posterior intercostal artery travels along the bottom of the rib with its corresponding posterior intercostal vein, as well as the intercostal nerve of the given space. The vein is superior to the artery, and the intercostal nerve is inferior to it. Intercostal arteries and veins. So what is artery? So the artery is the blood vessel that delivers oxygen-rich blood from the heart to the tissue of the body. Each artery is a muscular tube lined by smooth tissue. So the vein is a body blood vessel that carries blood that is low in oxygen content from the back of the heart. So the internal intercostal arteries and veins runs in the costal groove along the superior border. There are 11 pairs of artery that constitute the posterior intercostal arteries. Here is the sample of intercostal arteries and veins. Intercostal nerves are the somatic nerves that arise from the anterior divisions of the thoracic spinal nerves from thoracic 1 to thoracic 11. These nerves, in addition to supplying the thoracic wall, also supply the pleura and peritoneum. Intercostal nerves emerge from somatic nervous system from aid of the contraction of muscles, as well as to provide the sensory information in the skin and the parietal pleura. It supply the innervation to the skin and musculate the chest of the abdominal walls. Intercostal nerves. So that's it. Thank you.
Now we'll tackle about the suprapleural membrane. Superiorly, the thorax opens into the root of the neck by a narrow aperture called the thoracic outlet. The outlet transmits structures that pass between the thorax and the neck, and for the most part lie close to the midline. On the other side of the structures, the outlet is closed by a dense facial layer called the suprapleural membrane. This stent-shaped fibrous sheath is attached laterally to the medial border of the first rib and the costal cartilage. As you can see, it is attached at its apex to the tip of the transverse process of the 7th cervical vertebra and medially to the fascia investing the structures passing from the thorax into the neck. Also, it protects the underlying cervical pleura and resists the changes in intrathoracic pressure occurring during respiratory movements. Let us now proceed to the endothoracic fascia. The endothoracic fascia is a thin layer of loose connective tissue that separates the parietal pleura from the thoracic wall. The suprapleural membrane is thickening of this fascia. Moving on to the diaphragm. For the diaphragm, we'll discuss about the shape, the nerve supply, the function, and the openings of the diaphragm. The diaphragm is a thin, muscular, and tendinous septum that separates the chest cavity above from the abdominal cavity below. It is pierced by the structures that pass between the chest and the abdomen. Diaphragm is also the most important muscle of respiration. The origin of the diaphragm can be divided into three parts: the sternal part, the costal part, and the vertebral part. As you can see on the image, the right crus arise from the sides of the bodies of the first three lumbar vertebrae and the intervertebral discs. The left crus arise from the sides of the bodies of the first two lumbar vertebrae and the intervertebral discs. Lateral to the crura, the diaphragm arises from the medial and lateral accurate ligaments. The medial borders of the two crura are connected by a median accurate ligament, which crosses over the anterior surface of the aorta. The diaphragm is inserted into a central tendon, which is shaped like three leaves. Also, the diaphragm has three main openings: the aortic opening, the esophageal opening, and the caval opening. For the shape of the diaphragm located below the lungs is the major muscle of respiration. It is large, dome-shaped muscle that contracts rhythmically and continually and most of the time involuntarily. The diaphragm also has two nerve supply, which are the motor nerve and the sensory nerve supply. The motor nerve, where the right and left phrenic nerves are located, and for the sensory nerve supply, where the parietal pleura and peritoneum covering the central surfaces of the diaphragm are from the phrenic nerve, and the periphery of the diaphragm is from the lower six intercostal nerves. So basically, the diaphragm has four functions: muscle of inspiration, muscle of abdominal straining, weightlifting muscle, and the thoraco-abdominal pump. But to make it easy to remember, the main function of the diaphragm is that it contracts and flattens when you inhale. This creates a vacuum effect that pulls air into the lungs. When you exhale, the diaphragm relaxes and the air pushed out of the lungs.
The internal thoracic artery supplies the anterior wall of the body from the clavicle to the umbilicus. It is a branch of the first part of the subclavian artery in the neck. It descends vertically on the pleura behind the costal cartilages, a finger breadth lateral to the sternum, and ends in the sixth intercostal space by dividing into the superior epigastric and musculophrenic arteries. As you can see here in letter A, it is the internal view of the posterior end of two typical intercostal spaces. The posterior intercostal membrane has been removed for clarity, while on letter B, it is the anterior view of the chest showing the courses of the internal thoracic vessels. These vessels descend about 1 finger breadth from the lateral margin of the sternum. The branches of the internal thoracic artery split into three separate categories: anterior, posterior, and terminal branches. So here are some of the examples of the anterior, posterior, and terminal branches of internal thoracic artery. Two anterior intercostal arteries for the upper six intercostal spaces, perforating arteries which accompany the terminal branches of the corresponding intercostal nerves, the pericardiogophrenic artery, which accompanies the phrenic nerve and supplies the pericardium, mediastinal arteries to the contents of the anterior mediastinum, the superior epigastric artery, which enters the rectus sheath of the anterior abdominal wall and supplies the rectus muscle as far as the umbilicus, and lastly, the musculophrenic artery, which runs around the costal margin of the diaphragm and supplies the lower intercostal spaces and the diaphragm. The internal thoracic vein accompanies the internal thoracic artery and drains into the brachiocephalic vein on each side. So the internal thoracic veins are the companion veins of the internal thoracic arteries. The Levatorcostarum has 12 pairs of muscles. Each Levatorcosta is triangular in shape and arises by its apex from the tip of the transverse process and is inserted into the rib below. So the Levatorcostarum muscles are 12 fan-shaped muscles that elevate the ribs, but their role, if any, in normal inspiration is uncertain. They may play a role in vertebral movement or in proprioception. So here is the summary of the Levatorcostarum. Its origin is the tip of transverse process of C7 and T1 to 11 vertebrae. Its insertion is rib below. Its nerve supply is posterior rami of thoracic spinal nerves, and its action raises ribs and therefore inspiratory muscles. The serratus posterior superior muscle is a thin flat muscle that arises from the lower cervical and upper thoracic spines. Its fibers pass downward and laterally and are inserted into the upper ribs. So the serratus posterior superior muscle was said to elevate the superior foreribs, thus increasing the AP diameter of the thorax and raising the sternum, on the basis of its attachment and disposition. So here is the summary of serratus posterior superior muscle. Its origin is lower cervical and upper thoracic spines. Its insertion is upper ribs. Its nerve supply is intercostal nerves, and its action, it elevates the ribs and is therefore an inspiratory muscles. The serratus posterior inferior muscle is a thin flat muscle that arises from the upper lumbar and lower thoracic spines. Its fibers pass upward and laterally and are inserted into the lower ribs. So the serratus posterior inferior muscle was said to depress the inferior ribs, preventing them from being pulled superiorly by the diaphragm. So here is the summary of the serratus posterior inferior muscle. Its origin is upper lumbar and lower thoracic spines. Its insertion is lower ribs. Its nerve supply is intercostal nerves, and its action, it depresses the ribs and is therefore an expiratory muscle. So the next reporter will be talking about surface anatomy.
Surface anatomy. Anterior chest wall. The vertical bone of the chest, the sternum, defines anterior chest. Suprasternal notch is a superior margin of the manubrium sterni and is easily felt between the prominent medial ends of the clavicles in the midline. It lies opposite the lower border of the body of the second thoracic vertebra. Sternal angle, angle of Lewis, is the angle made between the manubrium and the body of the sternum. The position of the sternal angle can easily be felt and is often seen as a transverse ridge. It lies opposite the intervertebral disc between the fourth and fifth thoracic vertebrae. Xiphisternal joint is the joint between the xiphoid process of the sternum and the body of the sternum. It lies opposite the body of the ninth thoracic vertebra. Subcostal angle is situated at the inferior end of the sternum between the sternal attachments of the seventh costal cartilage. Costal margin is the lower boundary of the thorax and is formed by the cartilages of the 7th, 8th, 9th, and 10th ribs at the end of the 11th and 12th cartilages. Clavicle is subcutaneous throughout its entire length and can be easily palpated. It articulates at its lateral extremity with the acromion process of the scapula. Ribs. The first rib lies deep to the clavicle and cannot be palpated. The lateral surfaces of the remaining ribs can be felt by pressing the fingers upward into the axilla and drawing them downward over the lateral surface of the chest wall.
Okay, so this is my last topic, the thoracic wall. It have five contents. Oh, four. Sorry. It have diaphragm, nipple, apex, bit of the heart, and axillary folds. So what is the thoracic wall? So thoracic wall consists of a bony framework that is held together by 12 thoracic vertebrae posteriorly, which give rise to ribs that encircle the lateral and anterior thoracic cavity. So let's proceed. So first, we're going to talk about the diaphragm. So this is a drawing of the diaphragm. So the origin of the diaphragm can be divided in three parts: the sternal, the vertebral, and the costal. So diaphragm is a thin, muscular, and tendinous septum that separates the chest cavity above from the abdominal. So diaphragm is the most important muscle of respiration. So you need to remember that it is the most important muscle of respiration. It is dome-shaped and consists of peripheral muscular part which arises from the margins of the thoracic opening and a centrally placed tendon. Let's proceed. So um, here, the shape of diaphragm as seen from the drawing, the diaphragm curves up into the right and left domes, or cupoulae. The right dome reaches as high as the upper border of the fifth rib, and the left dome may reach the lower border of the fifth rib. So the nerve supply of the diaphragm is the right and left phrenic nerves, also called the C3, C4, and C5. The sensory nerve supply is the parietal pleura and the peritoneum. So the function of diaphragm is muscle of inspiration, and muscle of abdominal straining. Weight lifting muscle, thoracoabdominal pump. So, function of diaphragm are those four. Action of diaphragm: on contraction, the diaphragm pulls down its central tendon and increases the vertical diameter of the thorax. Opening of diaphragm is in the aortic opening, esophageal opening, caval opening. So those are the three openings of diaphragm. So now let's proceed to the nipple and apex bit of heart. So the nipple in the male, the nipple usually lies in the fourth intercostal space, about 4 inches or 10 centimeters from the midline, while in the female, its position is not constant. Apex bit of the heart. The apex of the heart is formed by the lower portion of the left ventricle. The apex beat is caused by the apex of the heart being thrust forward against the thoracic wall as the heart contracts. So here it says the heart is thrust forward with each ventricular contraction because of the ejection of blood from the left ventricle into the aorta. Force of the blood in the aorta tends to cause the curved aorta to straighten slightly, thus pushing the heart forward. So let's proceed to the axillary folds. The anterior fold is formed by the lower border of the pectoralis major muscle. This can be made to stand out by asking the patient to press a hand hard against the hip. The posterior fold is formed by the tendon of the latissimus dorsi muscle as it passes around the lower border of the teres major muscle. So that concludes the thoracic wall. So thank you for listening, and I hope you understand at least basic things from the basic learnings from the things I have said. So thank you.
So let's have here the lymph nodes and the vessel of the thorax. Below here we have the thoracic wall, mediastinum, thoracic duct, and the right lymphatic duct. So let's start here with the thoracic wall. The lymph vessel of the skin of the anterior wall drain to the anterior axillary nodes. The lymph vessel of the skin of the posterior thoracic wall drain to the posterior axillary nodes, and the deep lymph vessel of the anterior parts of the intercostal spaces drain forward to the internal thoracic nodes. So, the deep lymph vessel of the posterior parts of the intercostal spaces drain backward to the posterior intercostal nodes lying near the heads of the ribs. So from here, the lymph enters the thoracic duct. So next would be the mediastinum. They drain lymph from the mediastinal structures and empty into the bronchomediastinal trunks and thoracic duct. In addition to the nodes draining the lungs, other nodes are found scattered through the mediastinum. Next for the mediastinum would be the thoracic duct. The thoracic duct begins below in the abdomen as a dilated sac, the cisterna chyli. It turns downward in front of the phrenic nerve and crosses the subclavian artery to enter the beginning of the left brachiocephalic vein. So as you can see here, this is an illustration of the association between spinal cord, spinal nerves, and the sympathetic nerve trunks. So the thoracic duct receives the left jugular, subclavian, and the bronchomediastinal lymph tract, although they may drain directly into the adjacent large vein. So the thoracic duct thus conveys to the blood all lymph from the lower limbs, pelvic cavity, abdominal cavity, left side of the thorax, and the left side of the head, neck, and the left arm. Next to the thoracic duct, which is the last one, is the right lymphatic duct. This common duct, if present, is about 0.5 inches or 1.3 centimeter long and opens into the beginning of the right brachiocephalic vein. So the right jugular, subclavian, and the bronchomediastinal trunk, which drain the right side of the head and neck, the right upper limb, and the right side of the thorax, respectively, may join to form the right lymphatic duct. Let's have here the nerves of the thorax. Below here would be the vagus nerve, phrenic nerve, and the thorax part of the sympathetic trunk. Vagus nerve. The vagus nerve has two types of nerve, which is the right vagus nerve and the left vagus nerve. The right vagus nerve descends in the thorax, first lying posterolateral to the bronchocephalic artery, then lateral to the trachea and medial to the terminal part of the azygous vein, while the left vagus nerve descends in the thorax between the left common carotid and the left subclavian arteries. You can see here it passes behind the root of the right lung and assists in the formation of the pulmonary plexus. So this is the right vagus nerve. It passes behind the root of the right lung and assists in the formation of the pulmonary plexus. This way. And for the left vagus nerve, it crosses the left side of the aortic arch and it itself crosses with the left phrenic nerve. So it passes to the left aortic arch and itself crosses with the left phrenic nerve. And it assists in the formation of the pulmonary plexus. Phrenic nerves. The phrenic nerves arise from the neck from the anterior rami of the third, fourth, and fifth cervical nerves. So the right phrenic nerve descends in the thorax along the right side of the right brachiocephalic vein and the superior vena cava. And for the left phrenic nerve, it descends in the thorax along the left side of the left subclavian artery. So it passes in front of the root of the left lung and then descends over the left surface of the pericardium. The phrenic nerve processes efferent and the efferent fibers. So the efferent fibers are the sole nerve supply to the muscle of the diaphragm. Thoracic part of the sympathetic trunk. The thoracic part of the sympathetic trunk is continuous above with the cervical and below with the lumbar parts of the sympathetic trunk. So this is the sympathetic trunk. The sympathetic trunk has 12, often 11, segmentally arranged ganglia, each with white and gray ramus communicants passing with the first-body spinal nerve. The first ganglion is often fused with the inferior cervical ganglion to form the stellate ganglion. Branches. Gray rami communications go to all the thoracic spinal nerves. The first 5 ganglia give postganglionic fibers to the heart, aorta, lungs, and esophagus. The lower 8 ganglia mainly give prepolongionic fibers. Let's now hear the esophagus. Below here is the blood supply of the esophagus, lymph drainage of the esophagus, and the nerve supply of the esophagus. Esophagus is a tubular structure about 10-inch long that is continuous above the laryngeal part of the pharynx opposite the 6th cervical vertebrae. As you can see here, this is the thoracic part of the trachea. But at this picture, it shows here that the esophagus is 10-inch down to the stomach. The relation of the thoracic part of the esophagus: anteriorly, posteriorly, right side, and left side. Anteriorly, the trachea and the left recurrent laryngeal nerve, the left principal bronchus, which constricts, and pericardium, which separates the esophagus from the left atrium. Posteriorly, the bodies of the thoracic vertebrae and the thoracic duct, the azygous vein, the right posterior intercostal arteries, and its lower end, the descending thoracic aorta. For the right side, the mediastinal pleura and the terminal part of the azygous vein. The first side would be the left subclavian artery, the aortic arch, the thoracic duct, and the mediastinal. The blood supply of the esophagus. The upper third of the esophagus is supplied by the inferior thyroid artery, which is this one. The middle third by branches from the descending thoracic aorta, and the lower third by the branches from the left gastric artery. This one. So the veins from the upper third drain into the inferior thyroid veins, from the middle third into the azygous veins, and from the lower third into the left gastric vein, a tributary of a portal vein. Lymph drainage of the esophagus. Lymph vessel from the upper third of the esophagus drain into the deep cervical nodes. From the middle third into the superior and posterior mediastinal nodes, and from the lower third into nodes along the left gastric blood vessels and the celiac nodes. Nerve supply of the esophagus. The esophagus is supplied by parasympathetic and sympathetic afferent and afferent fibers via the vagi and the sympathetic trunks. In the lower part of its thoracic pores, the esophagus is surrounded by the esophageal nerve plexus. Thymus. The thymus is flattened bilobed structure lying between the sternum and the pericardium in the anterior mediastinum. In the newborn infant, it reaches its largest size is relative to the size of the body, at which time it may extend up through the superior mediastinum in front of the great vessel into the root of the neck. The thymus continues to grow until puberty, but thereafter undergoes invulation. It has a pink, lobulated appearance, and it is site for the development of T. lymphocytes. Blood supply. The blood supply of the thymus is from the inferior thyroid and the inferior thoracic arteries.
Thoracic Wall. Pleura. It is the boundaries of the pleural sac can be marked out as lines in the surface of the body. The lines, which indicate the limits of the parietal pleura where it lies close to the body surface, are referred to as the lines of pleura. Heart. It is for practical purposes. The heart may be considered to have both an apex and four borders. The apex formed by the left ventricle corresponds to the apex pit and is found in the fifth left intercostal space, 3.5 inches. Heart has three types. It is the left border, and the left border is formed by the left ventricle extends from a point on the second left costal cartilage, 0.5 inches, 1.3 centimeter from the edge of the sternum for the apex pit of the heart. Then the second one is the inferior border, formed by the right ventricle, and the apical part of the left ventricle extends from the sixth right costal cartilage, 0.5 inches and 1.3 centimeter from the sternum to the apex pit. The last one would be the right border, formed by the right atrium, extends from a point in the third costal cartilage, 0.5 inches, 1.3 centimeter from the edge of the sternum, downward to a point in the sixth right costal cartilage, 0.5 inches and 1.3 centimeter from the edge of the sternum. Our next topic would be thoracic blood vessels. It is the arc of the aorta and the roots of the bryocephalic and left common carotid arteries lie behind the manubrium sterni. The superior vena cava and the terminal parts of the right and left bryocephalic veins also lie behind the manubrium sterni. The last one is mammary gland. The mammary gland is clinically a very important structure because it is closely related to the bacterial muscles and its main lymph drainage is in the axillary lymph nodes. It will be fully described in the upper limb in Chapter 9. And to summarize briefly, the mammary gland lies in the superficial fascia covering the anterior chest wall, and in the child and in man, it is rudimentary, and in the female, after puberty, it enlarges and assumes its hemispherical shape.